अभी क्या कॉफी पिए हैं, कुछ अभी कूपन लेंगे तब ना। कूपन लेने तो 4 को लेके करेंगे। अभी तो हमको तो खुद
मैं सभा में उपस्थित सभी सम्माननीय एवं विशिष्ट अतिथियों का शिव की प्रिय नगरी अभिमुक्त क्षेत्र काशी में जहाँ भगवान शिव स्वयं राजेश्वर के स्वरूप में विराजमान है, हम पूरे काशी हिंदू विश्वविद्यालय परिवार एवं ऑर्गेनाइजिंग कमेटी की तरफ से आप सभी का सह हृदय अभिनंदन एवं स्वागत करते हैं। On behalf of Banaras University Varanasi and organizing committee second international conference of Indian Society of Sports and Exercise Medicine, we would extend a very warm welcome to each one of you present here to the inaugural session of the ISSEM on 2024 conference. So now I request all the dignitaries to please come forward and have a seat for the dais. So we have Professor Peter Rupner, Sports and Exercise Physician, Australia, Professor N.C. Sankwar, Director Institute of Medical Sciences, PhD, Professor Ashok Kumar, Dean Modern Medicine, Institute of Medical Science, PhD, Professor Gopal Nath, Dean Research, Institute of Medical Science, DHU, Professor A.K. Tiwari, sir, Head Department of Physiology, Institute of Medical Science, DHU, Brigadier Dr. Vibhu Kalyan Nayak, Director, National Center for Sports Science and Research, Sports Authority of India, Dr. S. Varun Sharma, Convener, ISSEM on 2024, and Dr. Sardar, General Secretary, ISSEM. Please have a seat. Ladies and gentlemen, जैसा कि हमारे देश की परंपरा रही है, किसी शुभ काम कार्य की शुरुआत करने से पहले हमेशा ईश्वर के नाम के साथ होती है. So ladies and gentlemen, before we begin anything auspicious, we always write the auspicious left.
A Merry Christmas all the deputies sitting on the dais to kindly guardian the words of Pandit Madan Mohan Malvishi and write the auspicious line. पंडित मदन मोहन मालवीय काशी हिंदू विश्वविद्यालय के स्थापक मानवता के उपासक एवं यज्ञशील चरण जोड़ Timing is supposed to bring a lot of positivity and time atmosphere. Here it is.
Thank you so much, sir. हमारी एक और परंपरा, किसी भी शुभ कार्य से पहले कुलदीप गायन किया जाता है। मधुर मनोहर अतीब सुंदर ये सर्व विद्या की राजधानी, ये पंक्तियां भारतीय रसायन और विश्वविद्यालय के प्रोफेसर शांति स्वरूप भटनागर द्वारा रचित है। Ladies and gentlemen, prayer is not asking, prayer is putting oneself in the hands of God. Now I would like to request the group for the Kuldeep. And it's a humble request to each and one of you. Please do not clap after the Kuldeep. Thank you, girls. And these girls belong to the faculty of performing arts. So we also thank to that faculty for sending us for the
Ladies and gentlemen, sports medicine is a specialized and distinctive branch which deals with the promotion and implementation of physical activity and exercise, health promotion, diseases, and prevention, treatment, and rehabilitation of injuries and illness, including chronic diseases of lifestyle, prevention, diagnosis, and treatment, including rehabilitation of injuries, offering physical activity in sports, early prevention, diagnosis, and management of medical conditions of injury and after physical activity and sports. So, over the next 2 days, this conference will provide you a plenty of opportunities to discuss and shape with you practical knowledge about sports management and exercise. Aditi Devabhav, we would like to welcome our esteemed guests by giving them a token of appreciation. First and foremost, I request Dr. IMS Professor S.S. Alva to welcome chief guest of the function, Professor Peter Pickle, Sports and Exercise Physician, Australia, by presenting in Thank you, sir.
Now I would like to invite Dean Research, Institute of Medical Science, PhD, Professor Gopal Nath sir, to welcome our Director, Institute of Medical Science, PhD, Professor S.N. Sanpal sir, representing our momentum and shown. So again, I'm requesting Dean Modern Medicine, Institute of Medical Science, to welcome our Director, Professor S.N. Sanpal sir, by presenting a memento and shown. Now I request Head Department of Physiology, Professor A.K. Tiwari sir, to welcome Professor Ashok Kumar sir, Dean Modern Medicine, Institute of Medical Science, DHU, by presenting a memento and shawl.
Now I'm requesting Dr. Varun Sharma, convener, ISSEM, to welcome Head Department of Physiology, and begin by presenting a memento and shawl. Thank you, Dr. Varun. Now again request Varun to welcome Brigadier Dr. Vibhu Kalyan Nayak, Director, National Center for Sports Science and Research, SAMI, by presenting a memento and shawl. And again requesting Dr. Varun to kindly present memento. Dr. Siddharth, Company Secretary, ISSM.
Thank you so much, sir. To welcome is to show honor. To welcome is to establish integrity. It would be a great pleasure to invite Professor Pavel Sharma to deliver the formal welcome.
Good morning, distinguished guests, esteemed dignitaries on the dais, respected speakers, delegates, and friends. It is both an honor and a privilege to welcome all of you to the second international conference of Indian Society of Sports and Exercise Medicine here in Kashi. We are gathered today in a shared commitment to advancing knowledge, fostering collaboration, and exploring ideas in sports and exercise medicine. And enthusiasm that each of you brings to this end is a testament to the importance of the conversations and connections that we are about to embark upon. Before we begin, I would like to take a moment to recognize and express our deepest gratitude to the distinguished dignitaries who have joined us on the dance today. Their presence here is a source of great inspiration, and we are truly honored to have them with us. Please join me in acknowledging Professor Peter Goodwin, Sports and Exercise Physician, Australia. Professor ISSEM, Director, Institute of Medical Science and Physiology. Professor Ashok Kumar, G, Modern Medicine, IMS PhD. Professor A.K. Tiwari, Head Department of Physiology, IMS PhD. Brigadier Dr. Vibhu Kalyan Nayak, Director, National Center for Sports Science and Research. Dr. Varun Sharma, convener, ISSEMCON 0024, who has taken all the things for this conference. And Dr. Siddharth. General Secretary, Africa.
Thank you so much, ma'am. Now I invite Dr. Varun Sharma, convener ISSEMCON, for the give a brief introduction about the conference.
the speed is very for and we also design getting forced to anyone's instruments. Yes, for that. So then again on the day there is a market it's very also to me that's how the environment is CDC. So the game was the lead and Russia as well as Brazil. And also we have lots of chronic concern, vascular concern. For us, that's what given the concern, was also there. And we also have also one island oriented our also the best in all others and we also have integrated medicine also. Integrated medicine also part of the and integrated also run by faculty in and on the 14, we have also skeleton test. Skeleton is I think first time we are doing this was hugely important when I was making specific medical part of the and we also have human experience because in research, not only in teaching social problem, so human experience is very important. Certain things is very poor. But that is the foundation. Human experience is strength of order. And also we have biomechanical analysis. Eating that also there. I think it was 100
more than 100.
More than 100 points. It was supposed to be a hands-on with a limited amount the requests we received because we can't demand them on the computer. So it was more than 100. The system has beautifully and you so on this 15 we will be starting different subsystems and physiological medicine. The physiological will be the one who will be starting with history of scale. And then we will have target screening. Target screening how to deal with some problems and other gaps. As we in Australia, after we have target screening, and then we will have sports medicine training and development scale where we will come up with. And that's all that's about. So we talking about sports medicine, exploring high potential. Then we will have emerging things and using different technology because in sports science and the perspective of NSCS, essentially one of the gems in India, is creating a high end of how we can then we have online session the co-writer of that title of this book, sir is hypertension in this book. Basically, speaking on the ground. So then the rehabilitation is really great. Experience and also consider all of this statement that loan management concept is also and we have public health. No, sometimes we get long-term health, short-term health, and maintenance. Long-term often neglected is the public. And sports games, we see the tourism field, industry, and also for Sneha, she's the director of and we have certain online system on for the non-physical sources because also on non-operating parts and the parliament from the US and we will end the session with the next we also have you to study yoga. Yoga will has been important and also then I know this coronavirus. I know is also important. I know exercise then we have exploring the innocence situation. Exercise is most important of any kind of and in order to approximately also that exposed to the industry and again the next portion need for we also have this audience how to do this. So these are so many things. So we will see and anyways.
Thank you, Dr. Varun. The leadership, vision, and unwavering support of all our esteemed guests for this conference has helped to make this gathering possible, and their ongoing efforts continue to shape the future of sports and science medicine. We are grateful for their dedication and for their contributions to the success of this conference. Over the course of the next few days, we will engage in thought-provoking discussions, share valuable insights, and build lasting relationships. Our carefully curated program features keynote speakers, panel discussions, workshops, etc. And we are certain that knowledge shared here will inspire and empower each of us to make meaningful strides in our respective fields. This conference is more than just a series of presentations. It is an opportunity for all of us to engage with one another, to exchange ideas and explore new pathways for collaboration. Whether you are attending virtually or in person, we hope you will take full advantage of the networking opportunities, the interactive sessions, and the chance to learn from the incredibly galaxy of speakers and experts we have gathered. Our participants, our speakers, our supporters, media personals, students, thank you for being here. Your presence is a powerful reminder of the importance of what we are about to undertake together. I encourage you to engage fully, ask questions, challenge ideas, and most importantly, to connect with one another. Together, we have potential to shape the future in ways that are both meaningful and transformative. We look forward to a truly inspiring and impactful age. Now, I request Brigadier Dr. Premu Kalyan Nayak, Director, National Center for Sports Science and Research, Science, to address the audience.
Respected Professor ISSEM, sir, the Director and PhD, Professor Udupa, Dean Faculty of Medicine and PhD, Diwali sir, Professor Gupta, Dr. Varun, and Dr. Siddharth, as and apart from that, all my seniors, surround us, and Latika Mohan, they have been my teachers and Dominic and Dr. Kulkarni. At the outset, I just wanted to compliment the team of PhD for organizing this excellent sports science conference, and it would not have come at a more opportune time. As all of us know, recently India has officially informed the International Olympic Committee about our aspiration to host the 2036 Summer Olympic Games. So all the more reason as you aspire to host the 2036 Summer Olympic Games, the role of sports science becomes much more crucial because not only during hosting we become a good host, but also as a sporting nation we need to prove that we also can do well in the platform when it comes to sporting performance. And a conference of this magnitude in this historic institution makes it much more special. And I look forward to a lot of discussion, sharing of knowledge, and future collaboration so that we work into a future where we are capable of contributing much more to our school system. And in the truly aligned to our ultimate aspiration where in a Bharat where each and every athlete gets an opportunity to attain their full genetic potential by virtue of having accessible and affordable human resources. This I sincerely wish this conference to be grand. Thank you.
Thank you, sir. Now, I request Professor E. Diwali, Head Department of Physiology, to address the audience.
Honorable, honorable members and audience, my friends, students. On behalf of the Department of Physiology, I welcome you all to this great center of learning, the great city of learning, and, and the city of temples. So, in next 2 days, variety of research papers will be presented, and the discussions, interactions will have one and all, especially the young minds, related to the exercise physiology and the sportsman. As we are aware that exercise physiology and the sports medicine, it helps to manage our lifestyle problems like obesity, so there's a variety of other things. So once again, on this auspicious day of Deepavali, I extend my warm welcome to all of you. Thank you.
Sir, Now, I request Dean Modern Medicine and Investigation and Sancho Martin NPC Office.
Thank you. Good morning. We're not going to prolong this inauguration beyond the minutes. Already we had a lot of deliberations and discussions, but immediately from the dais, my faculty, my faculty members, participants, students, I'm really happy to be here. Physiology, as we understand, provides a kind of foundational understanding of the practice of medicine. And without the basic understanding of physiology, we can't diagnose, treat, or go for rehabilitation on disease. I work with newborn babies, and almost daily we see the grand display of physiology when the baby is born, from intrauterine infection to life. Dramatic physiological take place. So it's a very fascinating. And the sports medicine or physiological medicine is extremely important role to play in preventing and promoting health, aesthetically, performance, and maintaining the health of society. So with these viewers, I'm sure this conference will be very useful. Thank you very much.
Thank you, sir. Now I request guest of honor, Director ISSEM, Professor ISSEMCON, to present this.
Thank you, Father. Good morning. Today, this document from Australia, for the secretary of the department, Dr. Vibhu Kalyan Nayak, and convener of this conference, Dr. Vasu Sharma, the faculty members of our ISSEM, the students, I have to welcome this conference of Indian Society of Sports and Exercise, the neurophysiologists, and the police, politicians. The same way they are doing in the field of the sports also. This will be a milestone for the future. The delegates, the faculty member, the students, their ideas, will get their knowledge, they will apply for the further teaching and for the management of certain situations. I hope this conference will be a milestone in the field of the sports and we are told by the Dr. Vibhu Nayak, improve your 360. So we are doing for this collective. Such conference is an idea to prepare our sports person in better way. To send my best wishes to Varanasi for this conference. Thank you very much. Enjoy our class. Thank you so much, sir, for your word of wisdom. Peter Bruckner, OM, is a specialist sports and exercise physician who is the founder partner of Olympic Park Sports Medicine Center in Melbourne and professor of sports medicine in Lathrop University, a founding executive member of the Australasian College of Sports Physicians. He served 2 terms as a president and played a key role in establishing sports medicine as a medical specialty in Australia. He has authored a book, A Fat Lot of Good. It's a best-selling book, was published in 2018. Dr. Peter is also the founder and chair of Defeat Diabetes, an app and web-based program aimed at improving diabetes control through diet. His latest book, The Diabetes Plan, was published in March 2023. In 2022, Dr. Peter was awarded a Doctor of Science honoris causa by Lathrop University and delivered the inaugural Peter Bruckner Distinguished Lecture. He was recently awarded in 2023 Premier's Outstanding Contribution to Victorian Schools Award. Ladies and gentlemen, I am absolutely delighted to present Chief Guest of the function, Professor Peter Bruckner, Sports and Exercise Physician, Australia, to address the event.
Thank you. Yes, ladies and gentlemen, it is a great honour and a pleasure to be here to your special guest. And I bring greetings from my Australian sports medicine colleagues. Our two countries have always been very close on the sporting field, and I look forward to similar to the closest on the sports medicine field. This is I think this is my third visit to your country. The first two were as doctor to the Australian cricket team. I'm scared to say it was less than successful from our point of view, but I'm hoping this visit will be much more successful than my visit. We're going to hear from you again shortly, so I won't say any more, but thank you very much for the invitation, and it's a real pleasure to be here. Thank you.
Thank you so much, sir. To embellish, to enhance, to enlighten, and to enrich the occasion. We are truly honored with your presence.
Our university dignitaries on the dais to unleash the prizes, the 23 Shoe of Olympic Sports by Professor A.K. Joy, Department of Sports Medicine, Women's and
So much. So, selected director of sciences. Sir, for the honor, to visualize the face and say, I'm happy to say about one. And the letters, Anna. Says, are yes, is please. I'm really happy that I'm invited. Oh. So, like in few words, we all wear shoes, and for the comfort and for the weight, and it has the man as a footwear, it has a footwear, but in sports, it's no more a footwear. It's a performing wear. It's part of the body that can make or break an adult. So it is a part of the body. It is so important, and most of the research is done on that. And the present shoes, sporting shoes are done for most of the research was done on this. So there are a few features. Actually, we are not aware whenever we find student, we don't consider what are the points. Like we consider only 4-5 points before we choose a shoe. Like does it support the foot? Does it give the stability? How is the we call it traction? How is the breadth of the shoe? And about the how much stability, how much responsiveness, because propulsion, shock absorption and propulsion, how much it helps. Last but not the least is breathability. Breathability is important for a long distance runner. So those issues are considered. We are never told it is the way our in terms of books to support this, and we had a series of seminars in our institute, and it's a compilation of those seminars, and that we have today. And it has got 14 chapters. We have included cricket. We may start out white cricket, and luckily or happily, cricket will be another again in 2020. I lost in the lesson, so we have included cricket also. So this book is mostly for the coaches, for the performing athletes, for the sports lover, for those who are on fitness. They will love this book and it will really help in their, like if they are developing the endeavor, this will really help them. So I'll consult at the end, thank everyone for giving this opportunity, and I wish Is happy Diwali today, and wish you all the best. ISSEM.
So now I request the referees on the dais to reveal another book under study cardiopulmonary science testing by Dr. Senthi Kumar Subramanian, Associate Professor, Department of Physiology, in Ireland.
You want to?
Going to know, in order to be there in this, so many. I will cut short reading. Book is about feedback or even exist testing. So many books, it seems very detailed and Bibles that are somehow along. But I'm just trying to give an Indian perspective for it. It's just a beginner's book. I will start taking the book so that you will understand what it is, then you get interest in the subject and so on. There are many co-authors along with me from all the different games. I'm very much thankful for them. And I will thank ISSEM for providing this. Thank you.
Now is the time to read the ISSEM text.
So this t-shirt, tie, and a pin is there of ISSEM. That's a kit which we are providing for ISSEM. With our notebooks, please, you can collect it out if you want inside.
Now let's express a word of appreciation and gratitude. I request Dr. Aegis in charge of Physical Education PhD for giving a vote of thanks.
Ladies and gentlemen, as we come to the conclusion of this inaugural session, it's not easy to stand before you and to try to find out the right words to express my gratitude. But yes, anyhow, as a part of inaugural program, I stand before you with immense gratitude and appreciation. It has been a privilege to be a part of such an inspiring and engaging beginning to second International Conference of Indian Society of Sports and Exercise Marathon. First and foremost, I would like to express our heartfelt thanks to our chief guest, Professor Peter Bruckner, Sports and Exercise Edition, Australia, for gracing us with your presence today. Your thoughtful words have set the tone for this event and have given us valuable insight that will guide us through the days ahead. Your commitment to sports medicine and your inspiring leadership are a source of great motivation for all of us, and we are truly honored to have you with us today. We also extend our sincere thanks to the dignitaries on the dais, Professor S. Sankwasa, Director, Institute of Medical Science, PhD, for being in the inaugural. Professor Ashok Kumar sir, Dean for Modern Medicine, IMS VHU. Professor Gopal Nath sir, Dean Research, IMS VHU and ISSEM. Professor A.K. Tiwari sir, Head Department of Physiology, Institute of Medical Science, PhU. Brigadier Dr. Vibhu Kalyan Naik sir, Director, National Center for Sports Science and Research, Sports Authority of India. Dr. H. Varun Sharma, Convener, ISSEMCON 2024, who has taken all the pain to host this conference. Dr. Siddharth, General Secretary, ISSEM. Your presence here today adds immense value to this event, and your unwavering support for the conference is deeply appreciated. A special word of thanks to the organizing committee and the volunteers whose hard work behind the scene has ensured that everything runs smoothly. Your meticulous planning and dedication have made today possible, and we are truly grateful for your tireless efforts in making this event a grand success. We also want to express our deep appreciation to our sponsors and partners for their generous support. Without your contribution, this event would not have been possible. To all our delegates, participants, and attendees, thank you for being here today. Your presence at this inaugural function signifies the importance of our collective effort and the shared enthusiasm we have for the goals and objectives of this event. We look forward to your active participation throughout the program. Last but certainly not the least, I want to extend my sincere gratitude to every one of you for your valuable time, your support, and your belief in the purpose of this event. As we begin this journey together, let us carry forward the spirit of collaboration, innovation, and learning that we have witnessed here today. And at last, I would like to thank the society under that aegis the conference is hosted, the Indian Society of Sports Exercise and Medicine. So thank you once again for making the inaugural function as a memorable and meaningful occasion. I wish you all the fruitful and engaging experience for the rest of event. Have a wonderful day ahead, and once again, thank you. And being in the Kasi, so you have to like give Namah Parvati Pate Har Har Mahadev. Thank you.
Yeah, thank you everybody, and we are now proceeding for the speaking sessions. Thank you.
अब उनका एक्सरसाइज Bill. Yes. So please come here then.
Which one?
Yeah. This one, yeah, this one, straight. That one, yeah.
Yes. That's what we can. If you have your hands and put there, otherwise they have a laptop. We just share the PPT with them. He has a so please coordinate. You need my laptop to do that. Yes, it's possible. They will arrange. Okay, so I don't need to upload it. No, nothing. If you have a pen drive, then you can give. Otherwise, if you're comfortable with your laptop, then fine enough. So whenever you are present, no issue.
Good, thank you.
Yes,
फाइल चेक करना मेरा लैपटॉप चलेगा यहाँ
सर चेक कर सकते
जिनका पहले अपलोड कर लो
पॉइंटर अभिजीत
So very good morning, ladies and gentlemen. We are starting with our first scientific session. So please have a seat so that we can start with our first scientific session. So we have among us Dr. Preeti. So we have it's a request to all the participants, please have a seat, and we are starting with our first scientific session. So we have Dr. Peter Brunner, sports medicine in Australia, and he is discussing about the Australian sports medicine story. So I am request sir to start with this session. It's coming. Otherwise, it's okay.
पॉइंटर लेके आइए भाई पॉइंटर आपसे मंगाए थे ना जल्दी आइए 5 मिनट क्या है? क्या है? चलते हुए। उसका है।
What are you doing? What are you doing? Just go back to. Wait, I mean, what are you doing? You just go back to the start.
One second. रुक जाइए। हो हाँ यस सर कोई दिक्कत नहीं सर
डुप्लीकेट कर लो।
हाँ कर लिया सर
कर लिया?
हाँ कर रहे हैं वही देख देंगे
अच्छा
We are really sorry sir for the delay. We had before. Technical features happens all the time. Try to prevent it.
ठीक हो गया
Online.
ये है ना सर का आ जाए वन सेकंड हाँ शेयर नहीं वन सेकंड ये नहीं है
हाँ right
यस सर
yes sir. So this was out.
हो तो रहा है हो रहा है सर हो रहा है
Excuse me.
अरे वो छोड़ा भाई
I think we're ready. So thank, sorry about that. So once again, thank you very much for inviting me to come and join you. When I was discussing with Dr. Curran what he would like me to speak about, I thought it might be interesting for the Indian society to hear a little bit about how we develop sports medicine in Australia and how we became medical specialists. So in many ways, you are where we were at the start of our journey. There were a lot of interest, a lot of passionate people about sports medicine. So let's look again about how you develop so the title of the Australian sports medicine is going from nothing to specialist. The story begins in 1985. It was a memorable year. I think it started in Oklahoma, in India. In 1985, was sort of the start of sports medicine really in Australia. And it was memorable for many years, memorable for other reasons. This is my favourite sporting ground. It's the Melbourne Cricket Ground, which is just not far from where I live and where I spend a lot of my time. And the highlight of the year that year was this day, winning the World Championship of Cricket at the UCG and final. So 1985 was a good year for India. It was a good year for Australian sports medicine. So what was happening in sports medicine in our country at that time was there'd been an organisation called the Australian Sports Medicine Federation, ISSEM, which was a multidisciplinary body. So they had doctors, physiotherapists, exercise scientists, nutritionists, etc. That had been in existence for over 20 years. They had an annual conference that was very successful. There was a course that I did when I was general practice back in 1983, run by the College of General Practitioners in conjunction with ASSEM. But one afternoon a week, it's a very basic course for general practitioners. That's all there was as far as education in Australia. There were a number of sports medicine centres starting up in Australia. They were multidisciplinary centres, and there were some in Sydney, some in Melbourne, Brisbane, but there was no postgraduate qualification in sports medicine, not even a diploma, a master's, there was nothing. So basically, you could watch a football match one day, and the next day you put a sign up saying sports medicine. There's no way of determining who had qualifications, who had experience, and who was competent in sports medicine. As I said, these sports medicine clinics were multidisciplinary. Doctors, sports doctors, orthopedic surgeons, physiotherapists, massage therapists, podiatrists, psychologists, scientists. And this is the one that I started in part of Sports Medicine Centre in Melbourne, which is the largest in Australia. We have up to 60 or 70 practitioners working at that centre. So back in 1985, received a letter. You know, the younger members of the audience wouldn't know what a letter is, but it's something that we used to correspond. We used to do it on a typewriter. That's probably only in museums these days, but that's what we did. We sent these letters, and we got a postman to deliver it in a letterbox. So radical for you younger members of the audience. But I received this letter inviting me to a meeting, and it was a meeting to discuss the formation of an Australian Association of Sports Divisions. And it was in Sydney. I live in Melbourne. It was in Sydney in those days. you know, why you see it was a big deal. Nowadays, we hop on if you go to the local bus, but those days it was a big deal. And I thought, no, let's go to this meeting. So I flew up to Sydney and went to the names of this association were as follows. I won't go through them all. They were admirable. And that's what we were saying. That was the information that I was sent and a number of other sports doctors around the country said. That was the agenda for the meeting.
सर वहाँ पे हम लोग स्टार्ट
So,
करते
yeah,
हैं
when we started on January 5,
अच्छा जल्दी परम सर गए वहाँ पे अच्छा अच्छा हाँ हाँ जी जी
so there on the left is Peter Pringer, and then myself, we're at the World
जल्दी से
Student
कर
Games that day. 20 people attended the first meeting. The chairman, Jim Siggins, got up and said, let's start a college. Let's start the Australian College of Sports Editions. And I was sitting in the audience thinking, "Man, just start a college." There's a Royal College of Surgeons, and Royal College of Physicians, and just start a college. We did. That day, we inaugurated the Australian College of Sports Editions. Subsequently became the Australasian College of Sports Editions, and our New Zealand College joined us. And later on, still the Australasian College of Sport and Exercise. That was the day it all started. The College of Sports Solutions. And due to the vision of this man, we established this college. So it's all very well to have a meeting and say, let's have a college. But we actually had to act on the college. And the aim of this college was to progress sports medicine from where it was then, no postgraduate qualification, no way of determining who was competent and who wasn't, no way of educating people, to the level of a medical specialty. Quite a challenge. Not been done before on new college in Australia. So we had a job in front of us. We initially, as you are here, at an annual conference, we had to establish a curriculum. What exactly was sports medicine? So my colleague, Scott Watson, a lot of time and effort into writing, determining what the curriculum was for sports medicine. It wasn't just injuries. It was much broader than that. It was medicine and exercise. It was very broad. We had to decide whether we would stand alone as a college or become associated or part of another college. We initially had discussions with the Australian College of Rehabilitation Medicine. There's a lot of overlap between sports medicine and rehabilitation medicine. And later the Australian College of Sports of Physicians. But ultimately, those negotiations did not progress. You can imagine if you're just starting up a specialty, if you like. One of the biggest challenges is to determine who gets the initial fellowships. Obviously, you've got to start with a group. You've got a group of experienced people who have been doing sports medicine for some time. How do we assess which of those are at the level of a specialty? Which of those have more work to do? We need a logo as well. That's our logo. It's the best logo in the world, but it's our logo. Now, as in this country, we inherited our medical system and our specialist medical system from the British. And you're a medical degree, you graduate with an MBBS after 5 or 6 years. You do 2, 3, 4 years of hospital residency. You sit a part 1 exam, a basic entry exam to whatever specialty you're going to attempt to join. And then, if you're lucky, you're admitted into a 3 to 4 year training program to become a cardiologist or a surgeon or whatever. At the end of that, towards the end of that, you sit an exit fellowship exam. At the end of it, you're either a specialist or a consultant. Specialists tend to be the surgeons who maybe don't spend as much time with their patients as physicians, and consultants are the physicians. And they, in Australia, they attract a different rebate rate. You get a lot more for a consultation as a consultant than you do as a specialist. Specialists can do all those fancy procedures and make all the paper. So that was the system that we inherited, and that was the system that existed in Australia. And so we determined that we should follow those guidelines to become a specialist. So one of the terms that we here use is grandfathers. You grandfathered in as a fellow. And so we had to decide, well, should the senior members of the sports medicine fraternity, you can imagine the equivalents sitting in the front rows here in your country, should they be just awarded fellowship and potentially specialty status, or do they have to sort of go through some examination process? And there was a lot of debate, as obviously we had vested interest too, and we didn't really want to do an exam. But we decided one of the important things, one of the big challenges that we had as sports physicians was credibility. Credibility within the medical system. Because I know a lot of our medical colleagues probably didn't regard us as quite as high, maybe intellectually and research-wise, with some of the other specialties. They're just sports docs. You know, they just run out in a football field or a cricket field, and that's all they do. So we felt it was really important to set the bar very high, so that we could get credibility within the other medical, broader medical profession. So we decided that no one would be grandfathered in. We would all have to sit exam. One of my colleagues, who was in his 70s then, had never sat an multiple choice exam in his life. He emigrated from Poland, and multiple choice questions didn't exist in those days. So he found it very challenging. But so everyone had to sit the fellowship exam before they became fellow of the ISSEMs. So the big question is, well, who's eligible? Who's allowed to sit this specialist exam? So what we did was we invited everyone, all the members of the group, to submit their CVs, and we assessed their CV to whether they had done the equivalent of a specialist training. So whether they'd spent a significant amount of time and had the necessary experience to be classified as having gone through the equivalent of a training program. And for those that we felt hadn't quite fulfilled that, we would assess whether they needed an extra year or extra 2 years, so on. So everyone got assessed as to where they stood in the sort of pecking order, if you like. There are 5 levels of advanced. So the inaugural fellowship exam was held in 1991. There were 2 written papers on multiple choice, 1 essay. One of the issues is, well, who examined you then? Because all the senior sports medicine people were doing the exam, who can examine you. And what we did do is we got a number of specialists from other colleges, rheumatologists, orthopedic surgeons, who've had experience in sports medicine to do the examining. So as someone who did the exam, I actually went from doing the exam one year to becoming chief examiner the next year, which is probably going to go with this year in drive. But the first year we just had non-sports medicine doctors doing the exam. The exam was held in Melbourne, 42 passes. And that was the announcement in the national newspaper in those days. That's how you send information out, either by letter or by announcement in the newspaper. And that was the announcement in the newspaper of the successful candidates. At our annual conference, we decided, well, we'll have a dinner here. We decided to make this a sort of a fellowship dinner where we awarded fellowships every year. And I suggested that we should make it a formal black tie dinner. And my colleagues all laughed at me and said, don't be ridiculous, we'll get a bit above ourselves there. And my argument was, this is going to be something really special to achieve. you know, you have gone through, you know, 4 years of postgraduate training exams and done all met all the criteria. It was quite an achievement. We wanted to make it, my idea was we wanted to make a big deal out of that achievement by honouring it at dinner, black tie dinner, have a formal presentation of the fellowships. Anyway, that was one of the few medals I won. And sure enough, we had a black tie dinner. This was in Canberra at our 900 conference. This was the inaugural cohort of fellows. Far too many men compared to women, and you're pleased to know the numbers are now easing up quite a lot. But in those days, you know, it was very much male-dominated. Women in the college were very upset when they see this photo of 4 women sitting demurely in the front row, and all the men behind them. So it's very, very sexist, which it probably was in those days. So they were the candidates. So we had an initial cohort then of fellows, of potential specialists. So we weren't specialists, obviously, but we were setting everything up to try and attain specialist status. And there they were. So then we had to establish a training program for those people who wanted to become sports medicine specialists. Now, the problem was that at that time, all specialty training in medicine was done in public hospitals, and therefore basically government funded. The government funded those hospitals, funded the salaries, and so the government, in effect, were really sponsoring the training programs for all of their colleges. The problem was, of course, there was no sports medicine in public hospitals, and there's still very little around the world public hospitals. So we had to establish training posts in private sports medicine clinics. The challenge then, of course, was that how were those going through the training program, which we call registrars, how are they going to be funded? We couldn't afford to pay them salary. So they were funded by a combination of consulting, we'll talk about that in a minute, orthopedic assisting, team coverage. So the idea was that, say, in their first year of training, they would spend the first, few weeks, months, maybe sitting in with the senior fellows, and then graduate to consulting in the room next door and being able to ask questions. And then as they went through the 4 years of the program, further and further down the corridor away from the sessions. But we were asking our fellows to train these people for no payment. There was no payment available to pay us senior fellows, especially dental specialists, to train these registrars. Whereas in the public hospital system, consultants are paid. Part of that is the expectations that they were teaching. So this is a very unique situation. See, there's never been a training program in Australia set up outside the hospital system. So in retrospect, we were crazy when I think that this would happen, but we were very naive and ambitious at the time. So we put an ad out for people who wanted to join the training program. 3 trainees or registrars, as we call them. Some of you would know John Orchard, who's the Chief Medical Officer of Clinic Australia. The character is John, and he was the only one of those 3 who actually went on. The next development was the following year. We joined with the Canadian Association of Sports Medicine, co-sponsored the journal. Gordon Madison, who was the editor of that journal, visited Australia. We developed a good relationship with him, and we became the co-sponsors of the clinical journal of sports medicine. Subsequent to that, we got involved with the British Journal of Sports Medicine at the time. Again, this is all just giving us credibility as well as giving us an avenue for our registration policy. The following year, further 35 were invited to sit in town. We've done an extra year of training. 30 stats, 17 passed, written, 13 passed. Now, around that time, a certain textbook started to appear. I probably should tell you the story about how that learned from critical sources. So back in 1992, I think, I wrote an article for one of the medical newspapers in Australia, Doctor, and 6 months later I'd completely forgotten about it, and out of the blue, I got an approach from the leading medical publisher asking me if I'd like to write expensive. And my immediate inclination was to say, well, no, I'm way too junior and inexperienced to do that. You know, it's only old ones who write textbooks. And I sort of said, no, thanks. And they were very persistent. And my colleagues reminded me that I basically criticized some texts that had been written. So organized in America, orthopedic based, and didn't really practice. So one thing led to another, and I said I wouldn't do that. I would write the textbook. And I conscripted my colleague Karen Khan with from a long conference to be my and basically became very much a team thing produced by clinical department sports medicine, and we really it was really a manual on how to practice. We were very keen for it to be a multidisciplinary, because most all of our textbooks, textbooks were very big, very orthopedic, very medical, and we really felt there was a huge audience among not just sports medicine doctors, but physiotherapists, massage therapists, podiatrists, and so on, for a book such as this. So with that in mind, we wanted to keep the price down. So I said to the publisher, we really like the price to be under $100. And that's now, well, we've done our sums and we're going to market it at $129. So, that was a lot of those, this is 1990, this is 30 years ago. It's a lot of money in those days. So we said to them, well, how do you, what's the basis of that? How do you base the price? They said it's all about volume. The more you print, the lower the price. So we said to them, well, how many are you intending to print first time? And they said 1,500. And so we said to the publishers, how many would you have to print to bring the price down to $99 for $129? They did their sums. They said we'd have to double it. We'd have to print 3,000 instead of 1,500. So I took a deep breath and said, okay, we'll buy 1,500. So, 2 authors, we bought $1,500, 1,500 books. We read by 1,500 books at the wholesale price. I was sort of absolutely never heard of anything like this before. And we set up a little system where people could. So in those days, all the journals and magazines were copy. There was no such thing as the internet or online. So we used to put little advertising leaflets into all the journals and newsletters and fill in name, address, and tick the box. You put in your check. And funny things that we used to pay money. Used to attach your check and post it off to our warehouse. And we managed to sell all 1,500 copies. Because the publishers are very good at the medical market, they had no idea about it. So we actually made a little bit of money out of it, but more importantly, we kept the price down. So the book was a success way beyond our sort of wildest dream. It was successful, reprint after reprint. And after a few years, they said, well, the book's a bit old now, it's over 5 years old, we've got to do another edition. And all that. And so we did another edition, and we've done another edition every 5 years since. We then realised we started to use it as a textbook. We never used as a textbook. So we thought, oh gosh, we're actually going to reference it now. So the first edition, I hardly any references, not there was much sports and some research around in those days. but we reference some sort of analysis about so the second one came out in 1999. The first colour one came out in 2005. 2010 was the fourth edition. Tim Powell, the Australian soccer player, played for Everton. It's presenting him with his copy of him on the front at Everton's training ground. And probably that was the thing so big because I hardly missed it. You know, I expected it to be used as a doorstop as much as a textbook, but it was getting to. So we decided for the next issue that we would have to do the two volumes. So fifth edition, which came out 5 years ago, we had volume 1, which is injury side of it, and volume 2, which is exercise. Well, it's now more than 5 years since then, so sure enough, we're out again. We're doing the 6th edition. Apparently, I stayed after the last one, but I never do another one, but somehow we've been forced into doing the 6th edition. And it's not just 2 volumes now, it's 3 volumes. We're calling it a trilogy. So I think we reveal exclusively to this conference that the first volume will be out next month. We're out with 2 old blokes, we're a lot older than the conference was when we started. There's the 6 books so far, and the next one is this one, coming out next month. So we're splitting the injury side up into a more of a general side, all the foundations of clinical practice, and then the injury side at the top of that. We're currently working on the second volume, probably the emails overnight, and that should be out in the middle of next year. And the third volume. Then, I'm sorry. Okay, you heard it now? If you ever hear any group, I might be doing it again. Feel free to contact me and say, you said you were going to do another one. No, definitely. So if anyone would like to take it over, well, that's the story about it's obviously part of the Australian sports medicine story because initially it was very much an Australian book. It's now become very much international. Over 100 authors in each volume. Our job, currently my job is to coordinate everything, sourcing the images and that. It basically takes a year of our lives in 5 months. So 2.5 years or whatever, but it's basically it's a full-time job for a year to do this experience. But it's a labour of love. I don't know why we continue doing it. We don't really need it for our careers anymore. We're both winding down our careers. But I guess I feel, and I think Karen would agree with that, but it's really it's due to the profession and the activity. So this will be the 6th of last one from us, and hopefully, as with medical textbooks, Harrison's been there for a long time, and still looking at Harrison's and Gray's certainly been there for a long time. Gray's an advocate. So hopefully we'll pass along after that. All right, let's get back to the story of college. We talked earlier about most colleges have an entrance exam, usually like a basic sciences exam. Surgeons will have to do an anatomy exam and so on. So we established our part 1 exam, which is anatomy, physiology, pathology, 2 papers. And in 1993, we had our first candidates, 5 candidates, all went on to become prominent. New Zealand friends, who there's more to it. In 1993, we invited them to submit the first exam. 8 of them accepted, 6 Australians. Still 3 of them. But no, it started a very good relationship with New Zealand colleagues, and sometime later, the obviously came to Australasia, which is a strange conferences in New Zealand every 3 or 4 years. Presidents now in New Zealand, and what was that so strong. So At this stage, we'd set everything up. We had our curriculum, we had our exam process, we had our training program. We thought, okay, it's time to bite the bullet and apply for specialist recognition. And there was a process in place at that time, NASPAC, the National Specialist Qualification Accreditation Committee, mouthful. But we commenced in 1994. We put our submission in to apply for a specialist. Now, all of our colleagues and people in other communities and people who new the system said it'll take you 15 years to get special recognition. Oh, quite ridiculous. It might have taken other people 15 years, but you haven't seen us in action. We'll get there in a lot less than 15 years. So, one of the things that was required was support from other medical colleges. So they were all asked to comment, and we then presented to all the other medical colleges as a group called the presidents of medical colleges. We get together every 3 months, so we presented to them. We were doing a lot of lobbying, I've been sitting outside parliamentarians' offices in Parliament House in Canberra, talking to them about sports medicine. So it was very much a political process. Here is the front page of our submission in 1990. Remember that date? Manual that we provided. Following year, again, we were looking for credibility. And so we then invited the other specialist colleges to observe our exams, to make sure that they were rigorous and they were high enough standard. And we established a board of examiners. We had specialists in this area run a series of workshops for us, and we really tried to raise our standard to a level of knowledge. Again, a lot of it, for them. So then, boom, 1999, just when we thought we were about to become specialists, the government in its wisdom decided to abandon the process, the NASPAC process. As to why they did that, no one really knows. So, you might do that every time. And you think they would come up with another alternative process. But no, there was no alternative process. And it took another 3 years before that alternative process put in place with the Australian Medical Council, which is the council that recognises proves of individual status, became the organisation to approve new specialties. So they developed a new process, subcommittee, expensive, we thought it was estimated to cost $50,000 to $100,000. We weren't a very wealthy college, but we all coughed up about an extra $1,000 to fund that specialty. We are one of 9 prospective new colleges applied for specialty recognition. But fortunately, we were the first one. If we'd been in the long list, we were the first one to consider. It was a 2-part process. First of all, we had to prove that sports medicine was a distinct and viable specialty in its own right. So it wasn't just a part of orthopedics, part of something else. It was a specific area of medicine that was unique to sports medicine. As you imagine, that was good. And secondly, once a specialty was approved, we had to demonstrate to the Australian Medical Council that we can provide the necessary training, accreditation, and specialty to establish this standard. 2-part process. We went through that process. This was the first one, 2007, that was approved. That stage 1 was complete. We went on to stage 2, and this was the document that we submitted in 2000. Assessment of coordinated science medicine. Then in 2009, whoopee, specialist recognition. Now you remember exactly 15 years after we started, which is exactly what they told us, and we said, no, rubbish, we will be much quicker than that. 15 years. Better late than never. So that was a very better time. 24 years since inception of college in 1985. 15 years after I understood. and literally hundreds of hours of work, parent solutions, lobbying, talking to people, which was a session for a small group of half a dozen of us. It spent 15 years trying to So interestingly, we're recognised as specialists. So I mentioned before the difference between specialists and consultants. But specialists traditionally have been research fields of colleges. Consultants have been more than medical colleges. And we applied to be one of the consultants, but they didn't grant us. They said you could be specialists but not consultants. So our rebate rates from the government, we got a system in Australia where the government rebates to patients for attending GPs or specialist consultants. GPs are this level of rebate, specialists at that level, consultants are that. So we're at the specialist level. And we have now spent the last 15 years, since 2009, trying to upgrade to consultants, and we've been unofficially told that's going to happen to consultants rather than specialists. So again, it's never ending. The constitution of happening to So that's really exciting news. I can't absolutely 100% further. Next week to announce in the So we're going to be consultants finally, which will be 40 years, exactly 40 years after we start. Anyway, so back in 2009, we had 138 active fellows. At the time, we had 27 registrars. That was the timeline from 1985 to 2000. Quite stark. So you pop it up in one slide and you think, oh, that's pretty simple. But that was 15 years, so 24 years. What about now? So I'll jump from 2009 to 2024. We're now the Australasian College of Sport and Exercise Solutions. We added the exercise partly to demonstrate that that's what we're here. Partly to sort of stake out claim that we were the exercise specialists rather than group holders or experts. And partly for political reasons, we felt that we broadened our sort of scope and our attractiveness, if you like, to sport and exercise solutions. And what there's over 250 fellows now, 50 registrars at any one time. It's now become very competitive. There was a period there before we became specialists where pretty much everyone who wanted to get onto the training program was able to. Now it's very, very competitive. I think we had 45 applicants this year for 14 classes, and they were really high quality. So I want to be discount, which is great. It's sad for people missing out. But the quality of people coming into sports clinics now is absolutely top quality. We have people who are top league medical courses, and people like that, rather than people like me. We still have an annual conference. Usually, we have an education program called the SEM Academy, which I think as I said, we think we're going to be consultants. And where do we work? Well, where do all these fellows, once they become specialists, where do they work? Well, there's still a lot of private sports medicine centres. So a varying sizes, some quite large, like the ISSEM in Melbourne, some multidisciplinary, some just sports physicians. There might be a group of sports physicians, 3, 4, 5, who form a practice together. And there are single sports physicians just working by themselves as consultants from GPs. So most are working at least part time. A lot of people do a hybrid job, where they might work 2, 3, 4 days in a clinic, then they do a day of research or a day with a team or something like that. So it's quite common to have a hybrid job. We have a number of national and state sports institutes. You may have heard of the Australian Institute of Sport in Canberra, going out for 30 odd years, very successful. Number of practitioners work there. And each state in Australia, we have 6 states and 2 territories in Australia, and they all have state and territory institutes who employ doctors and physicians. Professional sporting teams. Well, when I first started, back around that time in 1995, I worked for one of the Australian football teams, which is the biggest sport in Australia. And I would go down to training at the end of my day twice a week. So at 5 o'clock, I'd leave the clinic, go down and supervise training for 2 or 3 hours, and we would play a game on the Saturday. Nowadays, of course, we're all full time. Footballers and sports people are full time, and as a result, they require a lot more time from the medical staff. So you can actually be full time in the professional football leagues, Australian full time doctor, or many of them have 2 doctors who share and keep them. So there's plenty of work for sports physicians in professional sporting teams in Australia. Most professional teams have at least 1 sports physician as head of their medical team, and they complement that with a registrar or a GP resident sports medicine, or some cases emergency medicine physician. But nearly every professional fund would have a sports physician on their Olympic sports. You see, there are roles there for travel with teams and for attachment to teams. Personally, I work with 5 national sports: swimming, soccer, athletics, hockey, and football. So there are lots of jobs available. Yes, every sport basically has 4 teams: a men's and a women's team, and a men's and students who travel all the time. So there is huge opportunities to travel internationally. Which rarely, when you're in Australia, you're a long way from England. So the travel is at least 2, 3, sometimes 4 weeks. Essentially, they find difficulty finding enough people to travel. So there's lots of opportunities there. If you're the chief medical officer of sporting bodies, I mentioned John Hodgson before, so the chief medical officer for cricket Australia for some time. Cricket's been the chief medical officer for swimming, to like netball, and so on. So there are jobs there, which you usually time for roles, and different roles. Surgical assisting, there's always been a lucrative income in Australia from assisting orthopaedic surgeons, surgery. And so we encourage our registrars to do that, to supplement their income, and also to expose them to surgery and to an opportunity for them to see what the surgeons are doing. I personally think that once you're a specialist, you should be doing that, some models. And then there's some academic positions. I'm a part-time professor at Uttar University. There are a number of other sports physicians who have part-time academic roles in Australia. So as you can see, there's a whole variety of different areas for the sports physicians doing. So thank you for your time. I started off with an Indian triumph. I thought I should balance things out a little bit by it's painful. I know it's very painful to here. I still don't know how we won that World Cup last year, but we did. But we had your team arriving in Australia this week, and honestly, I don't think there's ever been as much anticipation for a cricket series in Australia as this time. Traditionally, England has always been our sort of our real arch enemy, if you like. But the amount of talk and publicity about this coming series in Australia is huge, and I'm looking forward to doing. I reckon 3 to Australia. Thanks so much.
Thank you to our esteemed speaker for the medical presentation. For expertise and insights and really enriched this session, and we are grateful for the knowledge you have shared with us. Now I request Professor S.N. Sudhwa, Director, ISSEM, will be present to esteemed speaker, Dr. Peter. Thank you, sir. I request now Professor A.K. Tiwari, Head of Department of Physiology, to kindly present the memento to Director IMS Selection, Professor S.N. Sudhwa. Now we are proceeding to our next scientific session. Pre-participation program for athletes allied arts
अरे यार आइएगा इधर ये मंच पे आइए।
sports
मंच पे आइए मंच पे आइए
Sri Lanka Sports Medicine
आइए
Association.
मंच पे अभी तो फोन कर रिमोट
छोड़ चलो क्या करते हैं? इसको वो कर हटा दे
अभिजीत से जाकर कहा कि रिमोट मांग लिया होता इसका अभिजीत इसका कैमरा का रिमोट वो लिए है ऊपर हाँ कैमरा का रिमोट कहाँ है ये
दिए नहीं है क्या नहीं है
लेके
देखा
आप पीछे जो बैठा कहाँ पे जाओ ये कृष्णा है कृष्णा कौन है देखो कृष्णा के हवा ठीक
हाँ? कौन सा है
वाराणसी
ये वाराणसी इलेक्शन है ठीक
कभी जरूरत नहीं कहाँ मांगना चाहिए लेकिन सर हाँ चलो
सर नेक्स्ट कर लीजिए एक बार टेस्ट करके चेक कर लीजिए नेक्स्ट हो रहा है
मिल गया
एक बार फिर
हाँ हो रहा है हो रहा है
ठीक है
Thank you very much. First of all, I would like to express my sincere especially from Dr. Sinami and Dr. Baru, So this is what we have done in Sri Lanka, and this more than a lecture, I'm just sharing my experience.
नेक्स्ट नहीं हो रहा
So these are the objectives of my talk. One is going to talk about some ideas and the previous data and how we have prevailed and some of things regarding screening program and immediate life support as well as post-class care. So the story begins in 2012. We had a tragic death of a young girl while she's participating in the non society. She collects and died. So before that also we had a couple of incidents, but we didn't make it out. But because of this social media and all the media, so this also big hole in the country. And not only that, that time we had a very enthusiastic politician, and he's more, he's a kind of one, like always hunting for these kind of things and make himself advice. So the president had a chat with the health minister, and all of a sudden, health minister spoke with us, and he said, president spoke to me, and doctor, you have to do something to prevent this kind of tragedy in future. So they made a circular. So we got the advantage of Gurna. So we got that advantage from the ministry, and we were able to establish a sportsmen's units all around the country in government hospitals, especially to minimize sudden deaths in sports, to screen the young athletes. So we got that opportunity. Now those centers are doing well to expand it. So it's dying a sports personnel, young, healthy athlete is devastating and very agonal or very bad news for the society, because society thinks the sports people or the athletes are the most healthiest people. So if they are dying while they are doing some kind of physical activity or exercise, that's a very bad thing. So the sudden death in sports, it's not only the sudden cardiac death, there are plenty of causes, but the sudden cardiac death take a big portion of the sudden death in sports. So almost more than 50% of sudden death in sports due to sudden cardiac death. But not only that, with the trauma, infection, and all sort of things will be other causes. So the sudden cardiac death in athletes, as a definition, is cardiac arrest during or within 1 hour of participating sports. So, but after doing a couple of postmortems and all the investigations, there are some deaths where we would not be able to find a positive cause. Especially in young athletes, that percentage is very high, because there's a thing called sudden arrhythmic deaths. They get cardiac arrhythmia. So you can't find any structural causes. If you had a previous ECG with you, yes, you will be able to find some sort of cause. But if this is first time, definitely you won't be able to. So I don't talk much about this because my next speaker, sports cardiologist, is going to be aware of this. But anyway, to complete my talk, there are broadly we can classify causes for sudden death, sudden cardiac death, especially the structural cardiac abnormalities and electrical cardiac abnormalities like shallowness and acquired cardiac abnormalities. If these kind of things is there, we then take. And with the strenuous exercise, sports, or strenuous activity, there will be a dehydration or high adrenaline surge and cardiac electrical imbalance and sometimes imbalance. So these things may precipitate ventricular fibrillation or ventricular cardiac. So
So the incidence in worldwide literature is not that much common, but there are a lot of meta-analysis going on, and but the incidence is comparing with the other deaths is very much less. All around the world, from USA to Australia, UK, Italy. So what we did, we went through basically two main guidelines. One is the 36 Bethesda Conference guideline, and the other one is European Society of Cardiology guidelines. So we went through all these guidelines and we made a special proposal for it. So what we did in Sri Lanka, we have a very good infrastructure for the preventive sector. You know, from the grassroots level, it's totally government based. From the grassroots level, we have public health lady who walk house to house and examine all these things. And there's a jet called public health inspector. So from that onwards, in each region, there's a public health doctor called medical officer of health, then regional director of health service, then the provincial director of health service goes up, and each and every sector there are directors like director NCD control, director antiviral area, director cancer. So that sort of preventive sector is there. It's well established. So we work with that preventive sector and we start training doctors, especially doctors who are working in as a general practitioner and primary health care level like outpatients department and emergency department doctors. We got together and each and every district we gave them a kind of a training. It's more the training is more with the medical and surgical emergencies. These are our team, both physicians, cardiologists and cardiovascular physiologists, emergency physicians, and medical administrators. And the topics which we discussed, those the training include medical and surgical emergencies, thermal-related problems, especially in our part of the world. This is one of the biggest problems, especially in military training, and basic life support and advanced life support. Not only that, the safety transportation as well. And physiological changes, especially cardiorespiratory changes in relation to exercise and sports. So because when we were medical students, we didn't concern much about these things in physiology. So we have to express these things as well. And basic ECG interpretation and some basic physiological changes in ECG in athletes and medical legal aspects as well. These are the products they are. So what we based is these are guidelines from American Heart Association. There are 14 different steps, 14 different steps, especially as when we were medical students, we went through this algorithm like history, examination, and investigation. So same like history, personal history and family history, and physical examination as well. So in history, especially exertional related chest pain and unexplained syncope or near syncope, palpitations, prior recognition of cardiac movement is very much important. And family history, sudden death or unexplained death before 50 years of age, and disability from heart disease in closer relative before the 50 years of age, or the cardiomyopathy or any child of the in family history, and evidence of connective disorders like marker. So these were the and with our team, so they made a questionnaire. So it includes more than 14 steps. It has 25 steps in questionnaire. So this was printed in main two languages. You know, the Sri Lanka we have native language for Sinhalese language, and there's Tamil community as well. So we printed in both languages, Sinhalese and the Tamil community, as well as English. So when the athlete comes, athlete or the guardian has to fill this whether each and every questions they have to read and fill up. So then the trained doctor will do a clinical examination, especially in relation to cardiovascular and respiratory system. But not only that, we check the weight and height BMI as well, because this may be the first incident where we will be able to pick up childhood obesity. So we are very much concerned on that. So we thinking about that. So all these pulse, blood pressure, better. I mean, so we instructed our doctors to check the pulse in both hands as well as the radiofemoral or the radial reading. So this is very much important with where you can find publication about that clinically and suspect and do the all the other investigations. So I know this in a busy clinic you won't be able to do all the thing, but pay attention on that. And especially cardiac murmur. If there's any kind of cardiac murmur, we always take with cardiologist. So there may be a mitral products or very silent murmur. So you must be very sure about that. But you might miss FOCA. So you have to be very careful of that. So we always take the cardiologist. And so this is the clinical examination form. After completing all, and we do ECG as well. So as a basic investigation, recent evidence says there are some instances, history and examination is equal to ECG as well. So there are some instances ECG is not necessary, but the not like in Prof. Bruckner's country, the ECG is much more cheaper in our setup, and we'll be able to do it very frequently. So because of that, we do ECG every year in almost all the categories. So in ECG, this is what we train our doctors regarding the normal ECG pattern and abnormal ECG pattern. If they found any kind of abnormal ECG, we advise them to refer the patient to relevant authority, either sports physician, cardiologist, or physician. So not only that, we can go ahead with all the other investigations. My colleague will mention all of these things. And especially ECG is mandatory. This especially in martial arts, running events more than 1,500 to 1,500 or more, and editing, swimming 400 meters or more, and race walking, hiking, martial arts. So all these events, ECG is mandatory in our setup. And not only that, it has to be, the children has to be about 12 years if they want to put them into a complete. So the history, examination, and investigation, after that we qualify them, or we can disqualify for the sports, that particular sports. Only thing is, we can't just send them away from sports. If they are doing any kind of strenuous sports, we would rather take them into a less strenuous or less stress to the heart sports kind of thing, because physical activity and exercise, over physical activity and exercise is mandatory and is one of the major goal in sports medicine practice. So if some player is willing to participate in a sports scenario, so we must encourage them, we do whatever, and if there's any life-threatening condition, so we have to minimize the strain on their heart. So according to this, we categorize sports and we qualify them. So these are the certificates we give for the athlete. These called pre-participation examination certificate, and there's another thing called pre-event certificate. If they are awaiting for the event, within 48 hours they should be fever-free, and there are some things as well. So you have to get the pre-event certification as well. Out of that, this pre-participation is annually. It is just 48 hours before the event. So the athletic disqualification is one of the major problem. You know, sometimes they may be preparing for the athletic event, or sometimes they are doing their training for a couple of weeks, and they must be collecting their costumes and all the equipments, rackets and all. Ultimately, when you say you are not suitable to these kind of sports, they will be very embarrassed. But you know, it's life-saving decision, so you have to take the decision then and there with all the evidence. Otherwise, you will be able to that athlete's life will be in a. So not only that, the screening is good, but there are some conditions where you won't be able to stop. Things like motion targets, if you get a big blow to the chest, you get some cardiac arrest. Whatever you do the screening, you get some cardiac arrest. So in that setup, you must know immediate life support and even the advanced life support as well. Not only that, you must do the safe transportation and post resuscitation and the rehabilitation process. So in my small talk, the take home message is exercise related death. Is very rare. So the issue of public perception may be not necessarily a public health problem. Screening and evaluation is mandatory. And whatever you do, the zero incidence, zero target is very unlikely. But you have to follow the guidelines and for the evaluation, even with cycles. Thank you very much.
Thank you, Dr. Udupa. Extend a sincere thanks to our speaker for the informative working presentation. Our contribution has added immense value for us. It will be appreciated for direct benefit. Now, I request Dr. Kiran Kumar Kulkarni, Sports Medicine Doctorate, Chairman, Medical Committee, All India Football Federation, kindly present a reminder as token of thanks to Dr. Kulkarni. Thank you, Dr. Kiran. I will now request Professor Latika Mohan Ram, Professor and Head, Department of Physiology, Claims Education, kindly present the comment. Dr. Kiran Kumar Kulkarni.
Which injuries? Yeah. Which injuries? Yeah. Varanasi.
Thank you, ma'am. We are now proceeding to our next scientific session. The topic is cardiac screening disease. The next speaker is Dr. Yuvraj, sports cardiologist, Leeds, United Kingdom.
ओके नहीं हो सकती ओके नहीं हो एक बार फिर से yeah. You need to yes nice slide I don't have I just got it. You need to connect cable to 1 minute
I got a USB-C to USB-C cable if you want that.
Yes.
Should I get it?
Oh, yeah. दिन काटा बनी ये सर काटा
फिर सर काटा
ये
सर ये सर का है
नहीं सर का कटने में
अच्छा
ये है
ये है ना ये मैंने सर पे पिटी बंद कर दी
ये सर का ही शुरू किया था सर का ही है
अच्छा ठीक है ये वाला है ना ना इससे ज्यादा परेशान
हम कहाँ पहला फोन आते परेशान क्या तो यार हर दौड़ा पहला
कंप्यूटर पे है?
अच्छा नहीं इस पे आ गया
नहीं है मेरे पास कंप्यूटर पे रखने वाला
अच्छा आप अपने कंप्यूटर पे
पहले बताया था मैंने
ठीक है सर
अभी तो लगा दिया था सर ये सर पेन ड्राइव में दिए थे तो
नहीं तो स्क्रीन पे आ जाएगा मैंने बोला था पहले बोला ठीक है तो
तो वो ठीक है तो फिर हमको ये पूरा सेटिंग करना पड़ेगा आपको सिस्टम
मेरे
लगाना
पास केबल है आप लगा सकते हैं
ठीक है
केवल कहाँ लगेगा सर
सीधा ही
सीटा भी इसमें नहीं हाँ इधर है देखिए तो
USB-C है
ना तो डिवाइस ठीक है वैसे करेंगे
हाँ
यार वैसे ही
अरे तो उस पे आना चाहिए
स्क्रीन पे ना तो ये वाला लगा दीजिए काम खत्म करिए ये लगा दीजिए सर सर ये आपके स्क्रीन पे लगा दें
आ जाएगा आ जाएगा
Hello everyone, I'm Dr. Zamba and I'm from Leeds in Yorkshire in England. I'm a sports cardiologist there. I'm pursuing my interest in sports cardiology now. Now, you probably must have heard of Leeds. It's a place where the well-known Headingley Stadium is. And I work in a place called Barnsley. You've probably not heard of this place, but those who've been following cricket in the 17th and 18th might have heard of Jeffrey Boycott. Well, he's from Barnsley. That's Jeffrey Boycott. And the famous umpire, Tiki Bird, is from Barnsley as well. He officiated the India West Indies finals in 1983. Now, my topic is on cardiac screening at least. And it might overlap with my previous speaker, so I hope to keep you interested. And at the same time, it's a good thing that reinforces the same message. I would like to thank the organizers for inviting me to give a talk on this very important topic of cardiac screening at least. And at the same time, thank you for giving me an opportunity to visit this city, the oldest and the holiest city in the world, a city older than tradition, older than history, as Mark Twain put it. Now, my topic. Hello. So my topic, I'll be speaking on incidents and causes of sudden cardiac death. I'll outline a few screening protocols, benefit and limitations of screening, and screening in UK and possibly in India. So let me start by showing you a couple of clips. Now this is a match between Cameroon and Colombia. It was played in 2003, so the clip is not that clear. It was in France, and the player we are looking at is Marc Vivenco, a 28-year-old midfielder. You can see in the middle of the screen, the player suddenly collapses. He's just 28-year-old, and in the middle of the match collapsed. They tried to resuscitate him, but he didn't make it. He died. He had a post-mortem, and the cause of death was found to be hypertrophic cardiomyopathy. The next clip is from match between Denmark and Finland. It is from Euro 2020, but it was played in 2021 because of COVID. And the player we are looking at is Christian Eriksen, a 29-year-old midfielder, a young chap. You can see in the far end there, a player suddenly collapsing. That's Christian Eriksen. Again, in the middle of the game, he collapsed. Luckily, he survived. He was resuscitated. He survived, and he now has a defibrillator inserted. Now, these are high-profile players playing a big-ticket tournament with telecast live all over the world. And they garner a lot of media attention. So let's come closer to home. You may be familiar with a local lad from UP, Rajesh Srivastava. Now, he collapsed while exercising in a gym in Delhi. He was taken to the hospital, but a few days later he died. He didn't survive. Similarly, this famous actor from South India, from Karnataka, Rajkumar, he again was exercising in a gym and he collapsed. Same thing, he didn't survive. Now, these are rare incidences. These are not common, but when it does happen, it has a devastating effect on the family, friends, loved ones, and this love they play for. So, how often does it happen? Now, a lot of people have looked at it, and they come to a rough estimate that it happens in between 1 in 1,000 and 1 in 100,000 young athletes. Young athletes, I mean less than 25 years of age. Whereas it is notably higher in healthy adult athletes more than 25 years of age. It is 1 in 7,000. And it is high because of the presence of coronary artery disease. Are at higher risk of sudden cardiac arrest if they participate in in exertional activities. Now it's a bit of a paradox here because sport exercise is generally associated with health, but you see there's clearly high incidence of sudden cardiac death in athletes than non-athletes. And why is that? It is because vigorous exercise generates a burst of sympathetic activation that can precipitate arrhythmias in genetically predisposed individuals. I'm again using the word genetically predisposed individuals. Certain sports like basketball, soccer, American football, they carry a much higher risk. It is because of the intense cardiovascular demand. Now, these sports are like start and stop sports, so they have an intense cardiovascular demand, and there's a higher risk of sudden cardiac arrest or death in these sports. Now, sports itself does not cause the cardiac abnormalities, but represents a trigger that can precipitate sudden cardiac death in those with certain pre-existing cardiac condition. Again, I'm stressing that pre-existing cardiac condition, and that's where the importance of screening lies. Now, this is a slide my previous speaker showed. This is the cause of sudden death in competitive athletes. And you can see the majority of the death is due to sudden cardiac death, more than 50%. And then comes the blood coma and other causes of death. Now, if we expand the sudden cardiac death further, this is the pie chart we get. SADS stands for sudden arrhythmic death syndrome. That's nearly 2/5 of the deaths because of that. and then you have the structural heart disease causing the other, causing cardiac death. Now, let me explain the various causes of sudden cardiac death. First is sudden arrhythmic death syndrome. Now, if an athlete dies and has a post-mortem, and on the post-mortem, the glucose is formed, the heart is actually normal, then it's generally put down the sudden arrhythmic death syndrome. Now, this is very difficult to find out in post-mortem, but if the athlete has an ECG or has been previously diagnosed with this condition, then it's easier to make the diagnosis. Or if the family member having this condition, or if they have genetic testing, then you can make that diagnosis. Now, this condition includes pre-excitation syndrome, WPW syndrome. Then there are some channelopathies like trauma to the chest, heat stroke, and illicit sexual abuse. Now, most of these conditions can be picked up on screening. So, what is screening? Screening is basically to look for a medical condition or disease before the symptoms occur. And once you can identify the patient at a higher risk of sudden cardiac death, and once you know that those patients can improve the prognosis by intervention. Intervention can be exercise modification or specific therapy. Now, who should be screened? I think all competitive athletes, should be screened, particularly those who take part in high-risk sports or with a family history of cardiovascular disease. Now, because of the advances in sports cardiology and the incidences of this high-profile death, the various cardiological societies and sporting organizations now recommend screening. I'll go through a few organizations. First, European Society of Cardiology. Now, they recommend screening starting at the age of 12 and 14, between age of 12 and 14, and a follow-up screening every 2 years till age of 25. They focus mainly on history, physical examination, and ECG. The American Heart Association, American College of Cardiology, they focus more on personal history, family history, and examination. They do not mandate ECG, but they don't oppose it either. And they do suggest follow-up screening every 2 years. Now, International Olympic Committee advises basic screening, ideally involving an ECG, especially in athletes in endurance sports or high-risk categories. And they do say you have to repeated screening. Now, FIFA has gone a step further. They collaborate with mental research, and they have a registry of footballers dying of sudden cardiac death. And they too obviously focus on the screening, history, examination, and ECG. And again, the athletes should have periodic screening. Now, the screening, what screening protocol should be followed? It's general consensus everywhere what should be followed. There should be a primary screening, followed by a secondary screening if something abnormal seen on primary screening. And if needed, advanced testing can be carried out. Primary screening consists of history, examination, and ECG. ECG is a bit controversial, but I'll come to that. And if you find anything wrong in the primary screening, you can go for secondary screening that consists of echocardiography. And if you need to confirm a diagnosis, you can have cardiac MRI or genetic testing. Yeah. So primary screening, the first bit is history. So history of syncope, pre-syncope of palpitations, that might suggest an arrhythmic condition if the patient got those symptoms or at least got those symptoms. Symptoms of chest discomfort or dyspnea, that might point to a coronary artery disease, especially in at least more than 35 years of age. History of murmur or valve disease, yeah, that can cause sudden cardiac death. And if there's exercise intolerance, that might suggest a cardiomyopathy or cardiac ischemia.
ये खान करके है
Now, another part of primary screening is family history. I think this is the most important bit. If there's a family history of a genetic disorder affecting the myocardium, now that actually thorough investigation, including genetic testing. If there's a history of sudden cardiac death in a younger member of the family, then the suspicion is raised that it might suffer from the same condition and should have further investigation. Similarly, if there's a history of coronary artery disease, history of angina or heart attack in a first degree relative, a younger first degree relative, then that it may be suffering from the same condition. Obviously, if there's a history of pacemaker placement or defibrillator, then obviously that needs to be looked further. Now, the next part is social history, where we look at substance abuse, tobacco, methamphetamine, alcohol. These can all affect the heart. And very important is use of performance enhancing drugs. Now, I doubt any athlete would come forward with this information. So, next part of primary screening is physical examination. Here, you check blood pressure, both arms and heart rate. Look for chest wall abnormalities, because chest wall abnormalities can be associated with congenital heart disease. Look for cardiac murmur. Obviously, that will point towards valvular heart disease. If there's signs of heart failure, signs of malperfusion like cyanosis or clubbing. If there's a radiofemoral arterial pulse delay, that might point towards coarctation of aorta, or the stigmata of Marfan disease. Basically, the whole idea of physical examination is to look for hypertension, valvular heart disease, Marfan syndrome, as these can cause or coarctation of aorta, as these can cause sudden cardiac death. The next part of primary screening is ECG. As I said, it's slightly controversial, but not that much, because the European Society of Cardiology recommends ECG as primary screening mechanism, whereas the American Heart Association are a bit conservative, and they say ECG should be used selectively based on history and physical findings. I feel ECG is a cornerstone of cardiac screening. Sorry about that. I think it's got a glitch there. I'll start again. Yeah. So now there is growing support for broader ECG use, as it can give in an early detection of asymptomatic conditions, like many conditions like hypertrophic cardiomyopathy, long QT syndrome, Brugada syndrome. These can be asymptomatic, and the first time one knows of this condition is when the person suffers cardiac arrest or sudden cardiac death. So it's a good thing to be these conditions are identified beforehand. ECG is non-invasive and it's easily accessible, and it can improve risk stratification by identifying potentially dangerous conditions and whether the athlete might need further investigation. I can give I'll show you ECGs, how ECG can be helpful in detecting electrical abnormalities. This is an ECG of long QT syndrome. This is a Brugada syndrome. WPW, Wolff-Parkinson-White syndrome, And then ECG can also give pointers towards structural heart disease, like hypertrophic cardiomyopathy. This ECG is quite typical of engaged strain of hypertrophic cardiomyopathy. And a right ventricular cardiomyopathy. Hence the epsilon wave there. ECG has its limitations as well. It can be a false positive or false negative. It is quite tragic, if actually as ECG changes and it will barred from playing, and undergoes further investigation, and then the thing it turns out everything's normal. It is also tragic that if the ECG is absolutely normal and that it plays and has suffers cardiac arrest. An example is Christian Eriksen. Christian Eriksen, I bet he plays for all top clubs in Europe, and I bet he would have thorough cardiac investigation beforehand, and still he had a cardiac arrest. Now, ECG interpretation requires expertise. Why? Because changes from the ECG in an athlete may be normal, but the same changes in a normal person can be abnormal. So it needs a sports cardiologist or sports cardiac physiologist to identify those changes. Now coming to secondary screening, there's a general consensus that echocardiogram is basically secondary screening. It assesses the structural cardiac disease, although the structural cardiac disease only represents a small fraction of the cause of sudden cardiac death. An echocardiogram is unable to detect non-structural cardiac disease, the electrical abnormality like WBW syndrome or Brugada or long QT. Echocardiogram carries cost. It costs money to have a heart scan. And again here, operator skill and experience is essential to distinguish between cardiac adaptation and cardiac conformity. Same as in ECG, more so in an echocardiogram, because athletes, endurance athletes have certain changes in the heart, like chamber dilatation, reduced ejection fraction, thick, myocardium. Now these changes can be normal in an athlete, but it will be abnormal in a non-athlete. So you need to be a sports cardiologist or sports cardiac physiologist to confidently distinguish between them two conditions. Now after that comes the advanced testing as needed. If you need to confirm a diagnosis, suspicion of a diagnosis based on the previous investigation. In patient or patient can have cardiac MRI or detailed structural evaluation. Can undergo stress testing for functional assessment in systematic athletes. And again, genetic testing for hereditary conditions that can confirm the diagnosis. Benefits of screening. Yes, cardiac screening is beneficial. It's useful. Now, in Italy, since 1982, this mandatory cardiac screening has taken place. Now, what they have done, they followed up these athletes for 25 years. And they have noticed that 90% decrease in incidence of sudden cardiac death since the cardiac screening has become mandatory. So cardiac screening is beneficial in identification of high-risk individuals and enables proactive management for early detection and intervention, for education and awareness. Now, screening educates athletes, coaches, and families on recognizing symptoms and seeking timely help. Detection of cardiac abnormalities, as I said. Now, this is important. Repeat screening increases the detection of cardiac abnormalities by threefold. Because that's why all these organizations, like sporting organizations, recommend repeat screening. Now, because some cardiac conditions do not manifest early on in life, but as time goes, they can be manifested and they can be picked up on screening. Now, screening has its own limitation and challenges. As I mentioned about ECG, it can give false positive, false negative, and it can not be so good if it gets false positive, false negative findings. This is very important. No screening program can prevent 100% of sudden cardiac death, as my previous speaker mentioned. Example is Special Erickson again. Although he didn't die, but he suffered a cardiac arrest. Screening costs money, and that's the main barrier for universal screening. Again, screening needs expertise and experience, especially cardiac screening. You need to be a sports cardiologist or a sports cardiac physiologist to distinguish between the cardiac adaptation to exercise and cardiac pathology. Psychological impact. There's an obvious anxiety from, in an athlete when they undergo screening. So they might be worried, what if there's something strong picked up? What is future of cardiac screening? Emerging technology, artificial intelligence for more accurate ECG precision. Now, artificial intelligence is a buzzword nowadays. It says that it can affect all aspects of life. So why should screening be left behind? I think artificial intelligence might be the future in cardiac screening. Advances in genetic screening and policy updates evolving standards and recommendation. As new information comes out, as new evidence comes out, the standards might change and the recommendations might change. So let me talk about cardiac screening in the UK. There's a body called CRY, Cardiac Risk in the Young. They conduct screening program in the UK. I'll come to that in a minute. And there's also elite athlete screening. Now these are like elite athletes are basically top-notch athletes playing for the country. And I mean the Football Association and the England and Wales cricket board, they got lots of money. So these screening is no problem. They go through all the screening programs. In fact, they might have MRI scans as well. But what about the average population? So cardiac risk in the young, that's a charitable organization that does cardiac screening young people between the age of 14 and 35. Now what they do is these are public events that people attend. They conduct, if I can use the word camps, they go to different cities in the country and they set up camps and they screen athletes or screen young individuals. One has to register for these camps, and in a day they screen 100 young people. The screening mainly focuses on medical history and an ECG, and there is a cardiologist or there's a physician there, and if the physician thinks that the person needs an echocardiogram, there's an echocardiogram as well, and the athlete or the young person can have a scan. Now, it provides free heart checks to 32,000 young people every year in the UK. And it's a charitable organization. It just works on charitable funds. Screening programs in India. Now, this I had to Google to find out what happens here. I found that this is mainly primarily private sector run programs. They have hospital and diagnostic centers, corporate health checkups. Now, Sports Authority of India, although it's not widely standardized, now Sports Authority of India has begun to include cardiac evaluation as part of health screening for athletes in national screening camps. Now, there's a potential of starting a screening program at grassroots level similar to CRY in this country, and I think ISSEM should take the initiative here. Now, in summary, cardiac screening saves lives, and it's not onerous. You just need a history, examination, and yes, ECG, I think. And I feel it should not be limited to athletes. Everybody should undergo cardiac screening. And it should be, ISSEM is a good body to initiate cardiac screening. Thank you. That's a picture of the outside here. And that's me and my wife watching the India Sri Lanka 2019 World Cup in Helsinki, which India won. Thank you. Yes, well. I think screening might be the same. So I learned for structural heart disease as well. Because I have seen in my practice as a cardiologist, post vaccination, post COVID cardiomyopathy, injection factors from certainly 20%. But some of them have to recover. But I think they would need all the screening for cardiac screening. And I think cardiomyopathy is a big yeah, myocarditis is called cardiomyopathy. So they have to restrict the activity while there's an acute inflammation there. But after that, it will be just like any cardiomyopathy, dehydration and slowly build them up. Well, HSCRP is more for is to be high in acute myocarditis, but for cardiac disease, that's what we look for. ISSEM. So we just monitor the CRP and just hit the echocardiogram and look for structural improvement or not. The new thing that's up. Yes, sir. Very good. We started there in the pertains to the common man, and there is a lot of awareness as far as the cardiac is concerned. And a lot of young that are taking place in generation. Popular boy in Bangalore. But people want to undergo it right straight away, don't COVID. Now the first point about existing on cardiac. I think people exist on professional activity cardiac. And for them, money is not a problem. So they can undergo all everything. In fact, those professional footballers, they might have an MRI scan when they join any club. So that's fine. But when it comes to grassroots level, I think cardiac is not affordable. Yeah, I feel ECG is mandatory. I think ECG is a must. And echocardiogram only if you can afford it because it is really private sector. You can afford it, you can have an echocardiogram, and I would recommend an echocardiogram. And family history questionnaire, examination. Now, the second question you asked about was a young person died suddenly. Now, yes, I have in my practice as a cardiologist, I see heart attack at age or even 40s nowadays, I see heart attack. Now, I feel if there's risk, what we call is a risk estimation, the theory before we call. If we put all the variables like age, sex, cholesterol level, ratio of total cholesterol to HDL cholesterol, smoking history, and rest of it, and you put in that algorithm and gives a risk of what the risk of death from or not death, risk of cardiovascular event in the next 10 years. Now, what we follow is that if the risk is more than 10%, then the person is still understanding and should undergo further investigation. That's because we do it in NHS, it's publicly funded, so we can't be aggressive with that. Whereas if it's a private person who wants to do it, I would recommend after the age of 25, if there's one risk factor they have in family history of diabetes, hypertension, I think that CD40 angiogram is a good investigation for that. Whereas MRI, I don't think it's necessary to go straight up for MRI because proper information can be provided, we can get it from the previous investigation. Only if you have to confirm a diagnosis or you're not sure what's happening, then you go for cardiac MRI. Yeah. And if the person's got some sort of cardiac condition he's not aware of, hypoxia might precipitate that. I think it's like, at least those going up there. Yeah.
कैमरा इधर नहीं, कैमरा आगे ना होगा, पीछे भी देना होगा ना, सबके सामने वैसे कैसे
No, I don't think federal test will add much. Because these are actually, they can do 12 minutes of group protocol without any problem.
स्टार्टिंग से ना हो
So,
सकता
no,
तुम जोड़
it's a false negative test for that. So, this is a provision, I think.
Two six four three.
Hmm?
2643
2 6 4 3
double 94
9
4 1954.
9
So we can take up more questions and then answer.
Okay. I'll come back. Thank you very much.
Yeah, thank you, sir. On behalf of everyone here. And now I will advise for.
Let me get my memento first.
This, so there's a key in joining pattern of source medicine. So it's lunchtime and we proceed with lunch. After this, let all the speakers, current speakers, kindly respect the time limit because they're very late. And yeah, so we'll be back to receiving the sessions after lunch. Yeah. Thank you so much.
ये लोड किया है
ISSM.
ये 15
कंप्यूटर में ISSM ये वाला
ये वाला है, अच्छा, ये है
ये वाला
ऐसे ऐसे थोड़ा सा फिर लगे तो लगे कुछ काम करोगे अदरवाइज इट इज लाइक सोर्स ऑफ इनकम चलिए
Thank you, everyone.
Sometimes we can slow next position in so this today is yeah, Australia's next birthday. It's like we can. So today my talk has sort of two parts. So I'll talk a little bit sort of what negative sports medicine is. It's a little bit about what makes different the biggest sports one. I see the volumes of and train sort of next presentation. These are others of which is probably showing because it's where we use health promotion aspects to it. Similarly, by that to so yeah, so that's just an overview of the so you already seen a brief extensive overview of the history on top. What you actually have to do training of this so what so specialist athlete is actually what but so we've already read about this from Dr. Brookdown, but where are we now? So what is that pathway? So now BS coordinates such a position in Australia. It's training. It's your fusion coordinates as a after 4 years postgrad. In that first postgraduate time, most of people line was your internship and residency. Then after that, you're encouraged to take general practice and people as well, or Moses training. As I said, minimum 4 years for practice. That can go for some people, maybe 10 years for or have work issues, so plantation in mind. But really what they want is setting up this sort of wide experience they use the program. One of the challenges that we is that most of the training is done in practice, so maximize your possibility of explaining learning like that. So once you enter the training program, it's a minimum 4 years internship program. So most people and it's also possibilities direct supervision was a lot of hands-on training. But again, things like what I mentioned before, surgical system, also spending time with cardios that sports cardios. So, this is something which is not unique for Australia, and I've seen it certainly with the content of this conference and also as well. Once, for people who now these aspects. So, one muscular little medicine is obviously a strong component. Most of this position, C, training, but should that exercise aspect of the exercise position after the title of the for exercise position, exercise prescription what is important in the considered training is having the ability to prescribe exercise not just in rehabilitation capacity, but also particularly chronic diseases, diabetes, sclerosis, cancer, those kind of aspects where each dispatch is to exercise those fields that are safe. That's significantly why it's also encouraged to be sort of public health. And involved in course, we know about the sports, the specific challenges, sports specific challenges. So one of the things in training is aegis the sports. So one of the sports, of course, is we want to trust them. So once you engage in that process, really what it is that these are the skills that we have. These are in excellent with fighting, rehabilitation, with skills, strategy, MRI, and also training through their training also take ultrasound training, but to complement external techniques as well. And the physiological aspect, which is really being strong, this conference that aspect is also. But I think there's a real strong emphasis on team and being a leader, system team, working with sports teams, as I said, something which the registrar asked you from medicinal training. And being able to handle those emergency response. And what is important is that the specialist doesn't become tailored towards just the sport, but there must be unity aspect. And the differences that exist between managers to managers, the lead and 7 days a week, access to that as a care, but also is the which improves both. So sorry about that. So how do you actually gain entry to the program? So we had previously, last year there was 45 candidates that 40 were selected to undertake Australia and New Zealand. But prior to that, to be eligible to apply, you can sit an exam as well. Exam is physiology, after the medicine, so you need to pass that exam. So once you pass the exam, then you're completed 4 years of general training, then you become able to.
Okay.
And studied the same thing. So once during training, system first, there's these supervised training program. This is clinical evaluation examinations which occur throughout, which are clinically oriented, but also working with sports teams, working with international explorers and other prerequisite, taking research, and as I mentioned before, at least 5 sports that you have to work with to train. To complete your training, then that's what you will do exams. So once you completed the prerequisite tasks and as well as research,
Hello?
that's when you sit first the written exam, which is both the MCQ and clinical cases. And once you pass that exam, then you can sit the live examination. Once you pass that, then so we can give amongst all that, there's the sort of process of position. This role is quite well defined in these terms. These roles are meant to be training and see the has now levels, and that includes position statements, working with those challenge, or items, as well. This involvement business. Research is an area where there has been some really great plans of research in Australia. It's probably an area where partnerships with media where there's stronger universities with public hospitals as well as and doctors that there is where we what is difficult in Australia is that sometimes to research that's very high scale and we can of course they obviously have education and continuous progression. So one of the things that our college has been involved in is the ISSEM medicine, which is has a goal and some states one of the leaders, then one of the providing an educational resource which is accessible to everyone globally, and again, covering all those trends. So medical as well as the university specific other aspects of research, these numbers, all this examination. These are some of the things that have been on access and pleasure to talk about. Discount code through the very moments,
कराया जो
these kind of education measures really help serve Australia's sports medicine. So, you know, I've done a lot of thinking about taste from for work career in sport medicine in Australia to be. I've taken a hybrid approach if you like, so my own this was first kind of a multi-stream clinic in Sydney, so it was dietitians, surgeons, physicians, but also engaging in exercises, working with cheap animals, large hospitals, and teachers. These was Sydney Fund, don't forget, but a lot of issues being Australia is that there's always a least international event coming up to the certain level. But also, yeah, so research, speech, stars. And then, you know, MCG was before, our conferences also help with to be able to engage with islands like this. But like anything, there are challenges, and the challenges that you know, speaking to accessibility, one of the things in Australia is that even has become very centric specialty. So it's in Melbourne and the main centres, but peripherally are less positions or less areas, but there's also less understanding than still medicine is, and that is not just from the public, general public, but also from specialists. So this process, specialties in meeting conferences and stuff like this, certainly very well. Certainly the training in this means the arts, the financial challenges. So we bring it to the second part of our lesson, and maybe this is just, as I said, which it applies to, but I think this is one where you can really see where sports position in how is a sports position we need to. So we don't how as a sports position to differentiate ourselves. We don't want to be specialists. So what are those big challenges? So we know this is an age group where there's rapid physical development occurring. Considering growth spurts, there's variation in gender, with multinational between cities. And we'll see also specific psychosocial aspects. So we know mental health rates or mental health disorder rates have increased rapidly, particularly during the period these became more. But there are also specific aspects to disorders like depression, anxiety, I think there's a bigger role for education and talk about safe practice and particularly exercise. That we're in the best positions, sports positions to go. And of course, that education is also some aspects which are so when it comes to sports, as a sports position, we're very much involved in understanding motor development, personal. This is where it's important that we apply this level of understanding how we apply our medical. So we see female growth below, the growth spurt goes on for about 3 years. So that has many challenges in planning the presentation, but also how we specific rehabilitation, bone functioning, or other aspects. We delve deeper, we can also see the differentiations in timing and how much time kilometer is in those small physical attributes, such as agility, speed, power, hypertrophy being more. So we go all together, very important when we apply having an understanding of when these milestones are occurring, because this is find out specifically the formation. When we got to one of those specifics, there are changes in time, changes. So these things ultimately impact when certain conditions may present. So keeping in mind that stages is important to know how we should actually apply steps, how aggressive we should be in our what are we saying, how often physiotherapy. So we know that line feel college is weaker, breath makes fragile and where it's from bone growth. So the bone density relatively reduces, so there's a risk of fracture, but also we see that in boxes. Muscle mass is critical in bodies, and maybe changes both. So we need more force to go. So, and then we talk about those aspects and strength and our. So all of those things being specific. So coming back to what are the things that we are involved in this sports position, we know ideology aspects. So as a college to be involved in the position setting similar to our association, European Cardiology Association, involved in position statements. So that's what everyone understand and that level of specialty knowledge. But probably more specific to these kind of checks that we're seeing, that aspect of sports specialization, which is something which is IOC, for example, but also general different nations are challenges that exist. And in Australia, generally, we've had considered to be able to aspects of that makes nations sports. And most kids would have played multiple sports. Seeing also this training where achieve excellence in sport. Level of sport, that sporting landscape is more limited in terms of what people have access to, and I think there are specific challenges like in the school in those physical. So these are some of the guidelines that have been offered from our college and association with the AIS when it comes to sports specialization. So this is an area of a sports position, it's the types of things that we have. We should require a specific guidelines. So in conclusion, the sports medicine and being a sport exercise position is in all the parts of the allows us to branch out into multiple areas, multiple disciplines, and
this kind of a challenge. Last night only I from the media that there are 14 athletes in the age group of 14 years. Yes, that will be very, very big. So that's the beauty of it, and that's what the doping, of course, the strength coming up, but we don't know that whether it will. We have this weightlifters 4.82 times 4.4. That's the battles at stake that we have it. Go into the various challenges that we face it in. Yeah, body intelligence, infrastructure again leads into more challenges for us. Where we have various mundane tracks and giving us every kind of injury problem. So I think I'll just sign over here. I already got to this thing. I was just to open our eyes in a way. Still, at least I have been. Two spikes. I still do not know when a young athlete and he said, "Sir, how many nails should I use?" The same question I had. Should I use 5 nails for my spikes, or should I use 6? What should be the length? Should I use 4 mm nails? Just answer. Try this. We will see how you perform. That's the beauty of science and coaching. So we will find the answers one day with all of you, especially the youngsters, taking up this. All of it.
Emerging trends and science or see as a fact.
हाँ भाई सर कौन सा है आपका ABHU टॉप
15 नवंबर
अच्छा ये
NCSS
हाँ, हाँ।
15 है
Presentation है?
Yeah,
Fine.
Pointer Yes, sir. Yes.
In one go,
दीदी आप कर लो सर्च मेरा मोबाइल
very fortunate that I have been thanks to give this talk after Professor Rao. But sir has been the pioneer in the field of so it's my sheer privilege to take it forward what he did, what all we should have undertaken 2 years, and how we intend to be. Start with National Center for Research. It's basically a central center scheme initiated by the government to support high-level research, education, and innovation. And they started in and they decided to run public school model.
करिए सर.
This is a very because government yes, really understanding. But there is a requirement of advanced food science laboratories so that the facility performance. Apart from that, also the technology is required to and finally so decided don't in this manner that we achieve what we intend. We created a database and center for it. Along with that, where complete ecosystem. Finally, we have to have a single source. As well as we did as a research. Till now, we have been following what has been because we still do not know what is that's very interesting in this is what I've seen that the even that is one of the minor ways we need to go what works for us. Finally, part of this scheme we building and we have science and technology. One can see, and then part of the scheme, cited five medical colleges, 6 universities are there. 5 medical colleges, they were single partner. And these colleges, one of the first were sports medicine, and they were out of this system again. Big confidence to his level of efficiency. Just to enumerate, though it's very long, but one has to find this. These are the centers that we have been, and these are the medical science universities. And what we do, recently it has been seen that we have got services for which holistic support to our first device.
ये तो उनकी जिसका presentation है
All things they have to be. is one can see, I start with money, start with the bank, go into all our center, money. Still there is. Psychology. We do not look at every kind of so that good area. Then comes the research. In starting streaming, we have put in the morning. This is what again our full experts is the is right. That's a small games physical exercises and relatively some this happen. This we are all say the government said this is the kind of the economic school in this part we have what speed with in all processes for the center services, efficiency, plan, so coming to the point, then those are this is what we have done. This all is a process. Please put psychology. What we have started. Get them trained for almost 7 to 10 days how to handle shooting sports. So recently, there are 4 types of ones and we have we are in the process of apart from that, for all we are coming up to the India standardized system. It's working. We gave them look at the same kind of services and same kind of. Also, we have got the leader source that again from that also says standardized.
Time by time.
We have already found there are certain challenges. I told you, we don't know recovery wise for our primary started with the first way was adding to have the in our country there are standing one science centers, the other is private centers, but so for them again how they can be standardized service support extended to them here. So back up the application system and the masters are helping our army. Yes, as I told you, we do not. And we are sensors with also even poetry. They are also focused on the recovery technology. Also, stress management. This is our intending the systems for variable. Yes, we are. By using this, you know, the tools. That is the first monitoring tool that we will primary given. So we are working on those. These are the systems can be really just and the still the person. We can end up and it has a in hockey schools where you usually decide based on the HRT decide to take the biomechanics results started there. Centers have some in place and whatever. Banaras. So during the part, we regulate this food space and to ensure that there is I think grass have been one small example searching on it's small like see the archer will drawing so as well for those that really but that is our data. So we are collecting the data. This data is being surface. So we are finding is in the and where the major structure are going to gain and then more we put that last deciding the complete that without scale I think the same. Yeah, was so we do how we improve skills and yes, to operate in silos. Once the testing is done, sit down and keep regular. All these two sciences data is software by sitting in the something like this again are where it actually on the so it does quantify what have been oxygen starting up the muscles for the training
चौटक में भी करते हैं
scale. What is the changes training program is changing normal. Yes, exactly. Covered all this. So this is the SOP again. Type 1 SOP for me. And this one again is happening at all. Same as one can see how long. This is the recovery.
टाइम कैसे इसमें 18 मिनट इसमें तो दूसरे बच्चे दूसरी बार जो है आई विल स्पीक
Saying, what would you
अच्छा इसी को देखना ठीक है
says on see maybe this what's on we had thinking saying what I think we have to do for our basic same thing standards what I want to say is that this is the quantum of the two psychologists and one sequence. So going ahead it's rather than start we have to this will be happening. Put everything in the streamlined manner. This is our some because now we have how they have salaries and how they individual state. Coming to the challenges, the first improvements, I found people of the speakers. Second is the from that. So this is the funding is this technology where we are going to be the biggest I don't know, but I will take more devising what kind of yoga is going to be different observation. From that, I was sitting there important. With Pilani, they are helping us now. So my active center is here. We are working with sum it up, we used to progress in basically, I mean, used to giving out support. We are also so that there is a which is players who have successfully they start full science in in India studies they have it's we just I don't know.
Should just stick to white quotation. So that we should have.
Just give us 1 year. It is done for all. I think it's a big. Once we have a respectable we are working on. The reason we talk about that and everybody will studying where it's a center is the do you this stand on in strategy focus to develop when it comes to this is starting where assessment
Yes, yeah.
But there is please fill out that.
After research findings, now that is true. Who, we have got all the approval from the government of India. And we guide you how to manage it.
Medicine, heart, wrist, injuries, delay.
See, I use them. What was it? What?
वो ठीक है स्लाइड चेंज
मैं ये चल का
Sun is coming.
रोल मैंने
let me
Not that one.
उसका पीपीटी एक मिनट
Loaded. I don't know.
और तो ये वाला है
Not that one.
पीपीटी का
Was already.
पीपीटी जी जी